Welcome to Pathology Central Key Concepts. The topic of this video is Introduction to Lymphoid Neoplasms. Now, since we only have one objective, review the basic features of acute and chronic lymphoid neoplasms, you may think this would be a short 5 to 10 minute video, but alas. The hematopoietic neoplasms are quite complex, and if you review normal hematopoiesis, you can see why. While we begin with a single hematopoietic stem cell that can then differentiate into a multipotent progenitor, we can then differentiate along multiple different lineages. And when you recognize that we can get malignant transformation of many of these cells, you can see why it can be so difficult not only to classify these tumors, but also to diagnose them. There is also some lack of agreement in the governing bodies that classify these lesions. So my goal in these videos will be to provide you with an understanding of the context so you will see why your patients present the way they do and why certain treatments are effective. There are a number of terms that we need to clear out of the way. The first of these are leukemia and lymphoma. So leukemias are neoplasms that present with widespread involvement of the bone marrow and peripheral blood, while lymphomas typically will present as discrete tissue masses of neoplastic lymphocytes. But these are not carved in stone. There can be overlap where we can get leukemias that are associated with a tumor mass and lymphomas that can progress to a leukemic picture. So these terms are used in the diagnosis to reflect the usual tissue distribution of the disease at presentation. So don't get locked into that. If you have a patient who has a lymphoma, but they have a leukemic picture, that is perfectly acceptable. We can also classify our lymphomas as whether they are Hodgkin lymphomas, which is a specific subset of B-cell malignancies, which I cover in a separate video, or whether they are the non-Hodgkin lymphomas, which are what we refer to here as the other lymphomas, follicular lymphoma, Burkitt lymphoma, etc. A term that I'll be using frequently in this video is blast, which is an immature white blood cell. We'll see more of those very shortly. And then the other concept that's important to recognize is that we refer to these diseases as acute or chronic. And this term refers to the disease progression. So an acute disease can kill a patient in weeks to months if not treated, and it tends to be composed of immature cells, so of blasts. By contrast, our chronic diseases may not need treatment for years. They can be very indolent. So there can be a delay in diagnosis when these are made because they don't have such an acute presentation. Now, I'd also like to spend a moment talking about this CD term, cluster designation. Now, you're already familiar with this to some extent because you're familiar with CD4 and CD8 positive T cells. The CD groups are these cell surface proteins that we use for immunophenotyping, which is very useful for diagnosis, either using immunohistochemistry or flow cytometry. And this is a list of some of the CDs and what they're associated with. Now, typically, it's good to know the CD3, 4, and 8. CD5 can be useful. When we talk about Hodgkin lymphoma, I'll be talking about CD15 and 30. And then we also have CD138 will show up later in this video. I don't really think you need to memorize these, but they can be useful in understanding the diseases we'll be discussing. Let me show you how we might be using these. So here we have flow cytometry, in which we send these cells past lasers, which can recognize both surface and intracytoplasmic proteins. So what we can see here is this is looking at two of these. One is CD22, which we've already described as a B-cell marker, and intracellular TDT, which is terminal deoxynucleotide transferase, a DNA polymerase expressed only in our pre-B and pre-T lymphoblasts. So this population up here will be the positive, and here's the positive. So you can see here we have a population that's positive for B-cell markers as well as TDT. This example here is looking at CD19, another B-cell marker, as well as CD10, which tends to be seen in our acute lymphoblastic leukemias. So taking these B-cell markers with our TDT and our CD10, we can look at this and say this is a B-cell acute lymphoblastic leukemia. So here is a graphic I put together to organize these thoughts for my students. This is focusing on the B-cell neoplasms because, as we'll discuss in a moment, B-cell neoplasms are much more common than T-cell neoplasms. And this is just a way to think about how these are related and to put them into with a few clinical pearls here as well. So you might want to use this as you review. Now, there are, as I mentioned, a wide range of hematopoietic neoplasms. We have lymphoid, myeloid, and our histiocytoses. This video is focusing on our lymphoid, so that's going to be our B cells and T cells. It can also be natural killer cells, but these are much less common. We're actually going to be focusing primarily on our B cell lymphoid neoplasms in this video. And this is going to include our acute leukemias, as well as our neoplasms of peripheral cells. And as I mentioned before, these are our non-Hodgkin lymphomas. The Hodgkin lymphomas, although lymphoid, will be covered in a separate video. So in our acute leukemias, we're going to have nearly all blasts, so our immature cells, that will be replacing our bone marrow. I'll also just mention here that the myeloid material is covered in another video, and I don't discuss histiocytoses because they are incredibly rare. Now, I've referred here to our non-Hodgkin lymphomas and our Hodgkin lymphomas. Let's take just a brief moment to get an idea of how these differ. So this is also covered in the Hodgkin lymphoma video, but we can see here that Hodgkin lymphomas have a very characteristic presentation where they tend to be localized as opposed to involvement of multiple lymph node groups. They tend to spread in a very orderly way from one group of lymph nodes to the next, and then at some point to the spleen and liver, whereas with non-Hodgkin lymphoma, we can see non-contiguous spread. There are a couple of other treats, such as which areas are involved. Hodgkin lymphoma very rarely will involve mesenteric nodes or Waldeyer's ring, and extranodal involvement is uncommon, in contrast to what we see in non-Hodgkin lymphoma. So they're very different types of malignancies. Now, these different types of malignancies will have different clinical presentations. So about 2/3 of our non-Hodgkin lymphomas, as well as almost all of our Hodgkin lymphomas, will present with enlarged non-tender lymph nodes. By contrast, what we'll see in our lymphocytic leukemias is that we're going to get bone marrow suppression. And this is because the bone marrow is filled with blasts, which is going to present the production of normal neutrophils, platelets, megakaryocytes, and red cells. So this presentation is typically going to be neutropenia, thrombocytopenia, and anemia. With our plasma cell neoplasms, we're going to get these masses and sheets of plasma cells within the skeleton, which are going to be lytic, so dissolving bone, and this can lead to a pathologic fracture due to bone destruction. We'll talk about this as well, that because of the release of immunoglobulins, we can get renal failure as well. But let's take a look here at what we mean when we say a hypercellular bone marrow. So here's an example where you can see that almost, this is nearly 100% cellular. All of these cells are here. And if we're looking at something like blasts or some other cell that's not producing normal cell types, you can see how it's going to out-proliferate and squeeze out our precursors for erythrocytes and megakaryocytes, etc. Now, when we're talking about our lymphoid neoplasms, we have our precursor B cell and a precursor T cell. These are our acute lymphoblastic leukemias. And then we have a peripheral B cell neoplasm. So I'm going to take these two first. So let's begin with our acute lymphoblastic leukemias. So as I mentioned, these are going to be composed of our immature neoplastic cells, so blasts. Now, with the mutations that we get in ALL, we're going to get complete maturational arrest at early stages of B and T cell differentiation. So what this means is that almost all of the cells that we see, the neoplastic cells, will be blasts. This is in contrast, which we'll see in acute myeloid leukemia, in which we can get about 20% blasts or more. The lesions that we see, the genetic aberrations, tend to result in dysregulation of expression or function of transcription factors that are needed for early B and T cell development. I'll go over one of these in a moment. And without treatment, death will occur very rapidly. So almost all of these are going to be B cell lesions, so 85%. These are patients who typically present in the years of 2 to 10. And they will present with symptoms secondary to cytopenias due to this bone marrow replacement by blasts. There is one translocation, which we typically associate with chronic myeloid leukemia, which we can see, chronic myeloid lymphoma, which we see here in BALL in children about 5% of the time, and in adults about 25%. The importance of this is that, like the other tumors that have BCR-ABL fusions, we can get treatment with tyrosine kinase inhibitors, which will be very useful for the patient. Now, the smaller subset is going to be your T-cell acute lymphoblastic leukemias. These will typically present in adolescence, and more than 50% of them will have a thymic mass, and we will also see bone marrow involvement. So there's a difference in the presentation of these tumors. So how do these patients present? So there will be an abrupt onset within days to weeks of the first symptoms. This is because we have an acute process. It's very aggressive. We have abundant blasts. So one set of symptoms will be related to decreased marrow function. So because we're not making red cells, we'll have anemia, and patients will present with weakness and fatigue. Due to the lack of production of platelets, we'll have thrombocytopenia, leading to petechiae and easy bruising. And because we don't have sufficient neutrophils, we can get neutropenia with increased risk of infections. Now, other symptoms will be due to the mass effects of the tumor infiltration. We can get bone pain due to marrow expansion with infiltration of the subperiosteum. This tumor infiltration can be seen in lymph nodes, spleen, liver, as well as the testicles. And in patients who have T-cell ALL with a mediastinal mass, that mass may be sufficiently large to compress large vessels and airways in the thorax. We can get meningeal spread, which leads to CNS manifestations such as headache, vomiting, and nerve palsies. So what do we see when we look at these cells? As I've already alluded to, we'll have a hypercellular marrow. Both our B-cell ALL and our T-cell ALL look very similar, so we can't tell just by looking at them. They will have scant cytoplasm with very fine chromatin, and will be lacking something called an Auer rod, which we associate with our acute myeloid leukemias. We'll talk about that in another video. They're going to express TDT, our terminal deoxynucleotide transferase, as well as CD10. This is the flow cytometry I showed you earlier. CD10 is very strongly associated with ALL. In fact, that's what is referred to, common ALL antigen, or CALA. So looking at these cells, in order to make the diagnosis, we'll use flow cytometry, which we've reviewed before. This is showing B-cell differentiation, so this is a BALL. Now, this turns us to our mature lymphoid neoplasms, and we're going to have a slightly different approach here. I'm going to go through a variety of characteristics of the mature lymphoid neoplasms and use various tumors to demonstrate why we see these. So let's begin with the fact that common driver mutations exemplify particular hallmarks of cancer. So the hallmarks of cancer are covered in the neoplasia chapter, and there are 2 videos on this as well, which you can review. Here you can see a table that I've modified from the one in Robinson-Kumar Basic Pathology, which covers some of the more common lymphomas, leukemias, as well as some of the salient morphology. But here we're going to focus on the hallmarks of cancer, which I've added in. So you can see things here like in SLL, CLL. We have overexpression of BCL2. Remember, BCL2 is anti-apoptotic. That's going to help these cells evade apoptosis. We see that as well in follicular lymphoma due to a BCL2 translocation. In mantle cell lymphoma, we get increased expression of cyclin D1. This takes us back to the RB and its role in the cell cycle, and we're going to get sustained proliferative signaling. And then finally, when we look at Burkitt lymphoma, we get a MYC translocation with amplification of MYC. Remember, MYC is involved in deregulating cellular energetics, taking us to Warburg metabolism. So I think this is a useful way to think of these different tumors. The second point I'd like to make is that most mature lymphoid neoplasms will resemble a recognizable stage of B or T cell differentiation. And in fact, this is why classifying these tumors is so difficult. Now this is a figure, again, from Robbins and Kumar Basic Pathology. They can be useful just if you're trying to put these into a slot, but I don't think it is useful at this point in your education to memorize all of these things. Say, oh, these are naive B cells and these are mantle zone B cells. This can be useful in terms of looking at immunophenotyping, but really at this point, unless you're going to become a hematologist or hematopathologist, it's just useful as a framework. Now, I've already alluded to this before, but most mature lymphoid neoplasms are of B cell origin. And the reason is that our B cells are going to be involved in class switching as well as somatic hypermutation. And these processes are prone to error, increasing our risk of malignant transformation. So many of the recurrent chromosomal translocations that you'll be learning about in Robbins that occur in mature B cell neoplasms will involve the immunoglobulin locus. So let's take a look for a moment at these two processes. This comes from a textbook from one of the other co-editors, where we just have an example here of heavy chain isotope switching. So here we have a cell that's making IgM, and at the IgH locus on chromosome 14, we're going to go through this process where we're going to be having recombination and cleavage to result in class switching to IgE. And if we get translocation occurring here in the processes of cleavage and recombination, that can result in malignant transformation. Here's another example looking at somatic hypermutation. Remember that we're going to be having this evolutionary drive to have higher affinity antibodies. So in our proliferating germinal center B cells, we're going to have a point mutation rate 1,000-fold higher than the spontaneous mutation rate in other mammalian genes. So that's what allows this selection to drive this high affinity antibody. So these antigen receptor gene rearrangements in our mature lymphoid neoplasms as well as in our immature lymphoid neoplasms can serve as unique markers of the malignant clone. Now this rearrangement will almost always precede transformation, and we can use this feature in diagnosis, in detecting minimal residual disease, and to exclude polyclonal or reactive proliferations. So for B cells, the way that we assess this is typically looking to see if we have a monotypic kappa or lambda expression. And we can do this using flow cytometry, immunohistochemistry, or the polymerase chain reaction. And I'll show you an example in a moment. For the T cell receptor, we typically use PCR or next-gen sequencing. So this is looking at a tumor that we'll be exploring in a moment. This is multiple myeloma, so this is a sheet of plasma cells. And in order to determine just a quick glance if this is monoclonal or not, we can do a stain for lambda and kappa. And you can see here that we have all of these cells, but there is a very minimal staining for lambda. This is probably just artifactual staining here. We don't see any cells with the nice circumferential staining that we should see. By contrast, this exact same field is 100% stained with kappa, so that strongly supports this being a monoclonal proliferation. We can also do this using capillary electrophoresis. This is doing PCR with some small amplicons. You can see these two here give a single band. So these are going to be monoclonal, helping us to make that diagnosis of neoplasia, whereas this particular tube is showing a polyclonal expansion, probably due to infection. The next point that you need to keep in mind as future physicians and healthcare workers is that lymphoid neoplasms will often disrupt our normal immune function. And we can get immunodeficiency and or autoimmunity, sometimes in that same patient. So for example, multiple myeloma, although we have abundant immunoglobulins, these are neoplastic immunoglobulins, we're going to have a decrease in our functional antibodies with an increased risk of bacterial infection. For one of the other tumors I've mentioned before, CLL, SLL, we can get autoantibodies to red cells in about 15% of patients. So let's take a look at our plasma cell neoplasms so we can explore this a little bit more. So plasma cell neoplasms are going to be B cell proliferations of our neoplastic plasma cells. They will be secreting monoclonal immunoglobulin, which is referred to as the M component, or simply immunoglobulin fragments such as kappa lambda light chains. This M component is large and is found in the plasma or extracellular fluid, whereas the kappa and lambda light chains can be excreted in the urine as Bence-Jones proteins. These can accumulate in the kidney where they are toxic, leading to renal failure. There is a spectrum of plasma cell neoplasms from multiple myeloma, which is characterized by multiple tumor masses throughout the skeleton, to plasmacytoma, which is quite uncommon, with a single mass in bone or soft tissue. And then we have monoclonal gammopathy of undetermined significance, or MGUS. This is very common in older adults and has a slow rate of transformation to multiple myeloma. It tends to have a small to moderate M component. Now, focusing on multiple myeloma, this is a fairly common disease in our older population. So about 30,000 cases per year in the United States with a median age of 70 years. These tumors have frequent IgH rearrangements, again, taking us back to why B-cell neoplasms are more common than T-cell neoplasms. Now, there are a variety of manifestations of multiple myeloma. We've already talked about these lytic tumor masses throughout the skeleton. As we dissolve that bone, that will release calcium, and that can lead to hypercalcemia with attendant neurological manifestations and GI symptoms. The point of talking about multiple myeloma is actually our defects in humoral immunity, and I'll show you a nice image that explains why we get this. This will increase our risk of bacterial infections. I mentioned renal dysfunction. We actually get renal failure in about 50% of patients. This can be because this abundant protein that's being shed can result in obstructive proteinaceous casts, or we can get this light chain deposition in the kidney. The light chains are toxic to renal tubular epithelial cells, and we can also get the buildup of amyloid, which is detrimental to the kidney. Hypercalcemia, which we just discussed, can lead to kidney stones. Now, with this attack on the kidney, we're going to get renal damage, which can decrease our EPO or erythropoietin production, leading to anemia. And we can also get the anemia of chronic disease or inflammation, so these patients may be anemic. So how do we make this diagnosis and what do we see? So radiologically, we're going to see multiple lytic lesions. In the serum or urine, we can identify this M component or light chains, and we can do a bone marrow biopsy that will show sheets of plasma cells, some of which may have globular inclusions of our immunoglobulins in the cytoplasm. This is referred to as Russell bodies. And then our immunohistochemistry is also useful with our CD138 positive for plasma cells, and then helping us determine if it is monoclonal. Now, this is a radiologic image, which is classic for multiple myeloma, these punched out lesions of the skull. This is not something I would consider pathognomonic. We still need to do a biopsy, but this is highly suggestive of multiple myeloma. Now, we also have a variety of laboratory tests. This is a serum protein electrophoresis, looking at a healthy individual and then a patient with multiple myeloma. So what we do is we load the protein and run it on a gel. What you can see here in the serum protein, this is just stain for universal proteins. This arrow is showing the area in which we would see our immunoglobulins, or IgG. These are other serum proteins. Now, the way we visualize these actually is that we fix the protein and then we'll visualize it with an antibody to the particular immunoglobulin they're interested in. So IgG, IgA, IgM, kappa, and lambda light chains. So in a healthy individual, you can see you have nice polyclonal IgG. You have a small amount of IgA. And then we don't really see much IgM. We have a stronger kappa than lambda, but both are expressed. So this is a very typical appearance. By contrast, in an individual with multiple myeloma, they are churning out vast amounts of this one immunoglobulin, this neoplastic clone. And this happens to be an IgG. So we have this single discrete band, but you can appreciate why this patient has got some immune dysfunction because we don't have the rest of our smear here of our polyclonal IgGs. We don't see really any IgA or IgM at all. And this is confirming that this is going to be a kappa chain. So this is IgG with kappa light chains, very few lambda chains present at all. This is a biopsy of an individual with multiple myeloma, and you can see why we are so reliant on our immunohistochemical stains and flow cytometry, because these just look like little round lymphocytes. Although we can detect that they are plasma cells, a little bit of eccentricity to the nucleus in the cytoplasm. But we don't need to ponder. We can do a CD138, which highlights all of these cells, and then we do our kappa lambda, which I've shown you earlier, again showing this has got a kappa light chain. The sixth area I'd like to discuss is has to do with the immunodeficiency. So immunodeficiency increases the risk for certain lymphoid neoplasms, particularly those associated with Epstein-Barr virus infection. We actually see a number of EBV-associated lymphomas. The one I'm going to talk about is Burkitt lymphoma, in which 25% of the HIV-associated tumors are Epstein-Barr virus positive. So Burkitt lymphoma is typically referred to as being either endemic or sporadic. So it's endemic in parts of Africa and sporadic elsewhere. It's due to dysregulation or overexpression of the MYC transcription factor, which is a master regulator of Warburg metabolism, as we discussed, leading to very rapid cell growth. And in fact, Burkitt lymphoma is one of the fastest growing human tumors. It's characterized by intermediate-sized lymphocytes with very brisk proliferation, leading to what is referred to as a starry sky pattern. Since we have this very brisk proliferation, we get apoptosis. Macrophages will consume that apoptotic debris and give this punched-out look, which we'll see in a second. It tends to affect children and young adults. In endemic areas, it will present typically as a mandibular or maxillary mass, and we say that nearly all are Epstein-Barr virus positive. By contrast, in North America, we tend to get abdominal tumors of the bowel, retroperitoneum, and ovaries. And of these sporadic tumors, 15 to 20% are Epstein-Barr virus positive, whereas, as I've already mentioned, about 25% of the HIV-associated tumors are Epstein-Barr virus positive. Now, these are highly aggressive tumors with this brisk proliferation, but with intensive chemotherapy, the majority of patients are cured. So I think this really nicely shows that starry sky appearance. You can see these bright punched out areas. On higher magnification, you can appreciate these are macrophages that have little bits of apoptotic debris within their cytoplasm. Here's another image. This is from your textbook with a slightly different fixative, which allows us to not only appreciate our apoptotic bodies here within our macrophages, but also this brisk mitotic activity. Here's a mitotic figure. Here's another. So this is proliferating very rapidly. And this is just an immunohistochemical stain for MYC showing how abundant it is in this particular tumor. Now, another feature of these neoplasms is that the neoplastic cells tend to recapitulate the behavior of normal counterparts. So we see this as well in our well-differentiated carcinomas, perhaps, that are continuing to elaborate hormones. We see this in our hematopoietic cells, in which they still will express the same adhesion molecules and chemokine receptors, which is going to result in them homing to particular tissues. So, for example, follicular lymphoma cells will home to the lymph node germinal center. This gives us our opportunity to discuss follicular lymphomas. So follicular lymphomas tend to occur in an older patient population, older than 50 years, with equal prevalence in males and females. More than 85% of cases have a chromosomal translocation between chromosomes 14 and 18, and this will result in the fusion of the BCL2 gene to the IGH locus. This is going to result in an increase in our BCL2 protein, which again is going to inhibit apoptosis. The neoplastic cells, as I've already mentioned, are going to home to the germinal center, and we will have what is referred to as nodular effacement, and I'll show you that image in a moment. The neoplastic cells are composed of centrocytes and centroblasts, with the centrocytes being slightly larger than resting lymphocytes with a cleaved nucleus, and centroblasts being larger cells with vesicular chromatin. This is a fairly indolent disease, but is incurable, something that we'll see frequently in our hematopoietic neoplasms. The ones that are more aggressive, you tend to have a higher chance of cure, because with rapid proliferation, you have the opportunity to disrupt that proliferation. Now, although it is indolent, about 30 to 40% will progress to an aggressive neoplasm that is very similar to a diffuse large B-cell lymphoma. So this is showing this nodular effacement in follicular lymphoma. This is a lymph node, and you can see here that the follicles vary in shape and size, from smaller to quite larger. And as we look at this image from your textbook, you can see these typical cleaved nuclei that we associate with follicular lymphoma. Now, I refer to this as a nodular effacement. What we're talking to is that we've lost our typical architecture of the lymph node with the arrangement of our germinal centers. And we can see here a comparison of diffuse effacement, which we typically associate with, for example, a small lymphocytic lymphoma, chronic lymphocytic leukemia, in which there are no nodules at all. It's just sheets of cells. This is in contrast to the follicular lymphoma here, where we have this nodular or follicular effacement. Now, the point of this was showing that the malignant cells homed to the germinal center. How do we know? How can we see this? As I've mentioned, we tend to have overexpression of BCL2 in our follicular lymphoma cells. So this is looking at a healthy individual whose lymph node is just reactive. When we stain for BCL2, the germinal center is devoid of staining. There's nobody here who's expressing BCL2. But in a patient with follicular lymphoma, we have our germinal center, and this is where all of our follicular lymphoma cells are. I already mentioned they express BCL2. There's our strong staining there. Another important consideration is that most non-Hodgkin lymphomas are widely disseminated at diagnosis. So while we do lymphoma staging in Hodgkin lymphoma, we don't use that for non-Hodgkin lymphomas. And it's also important to recognize that our non-Hodgkin lymphomas, because they're widely disseminated, are going to require systemic therapies. One exception to this will be our extranodal marginal zone B-cell lymphomas or maltomas. So we'll talk about that in a moment. But before we go there, I want to digress briefly and talk about the staging in Hodgkin lymphoma. This is covered in the Hodgkin video, but worth thinking about now. So this is how we look at staging in Hodgkin lymphoma. The goal is not for you to memorize this, but just to recognize these are the features we look at. Is it a single lymph node or region? Are we on one side of the diaphragm or both sides? This is how we look at staging in Hodgkin lymphoma, but not in non-Hodgkin lymphoma. So this gives me the chance to talk about extranodal marginal zone lymphomas or maltomas. You're going to see these again when we talk about gastrointestinal tumors because of their link to Helicobacter pylori gastritis. So this is a heterogeneous group of B-cell tumors referred to as maltomas or mucosa-associated lymphoid tumors. They typically will rise in chronically inflamed tissue. So this is again one of our what we call the hallmarks or the enablers of malignancy. So we can see them in Helicobacter pylori gastritis, Hashimoto thyroiditis, or Sjogren's syndrome. They typically will remain localized for prolonged periods and may even regress if the inciting agent is eliminated. So let's look at the pathogenesis of these tumors. We have something that stimulates our immune system. So it can be an antibacterial immune reaction or an autoimmune reaction. This is going to result in a polyclonal B-cell proliferation that over time can develop additional mutations. These mutations can lead to a B-cell clone that is supported by inflammatory cytokines secreted by antigen-specific T cells. These T cells will then support tumor cell growth and survival. Now, if we were to eradicate the antigen-specific T cells, this inflammatory stimulus, either, for example, by using antibiotics to eliminate H. pylori or some sort of immunosuppression in autoimmune disease, we can get regression of the lymphoma. But if we don't eradicate the inflammation, we can get further clonal further clonal evolution, leading to distant spread and progression to a large B-cell lymphoma. And that is what we see here in this individual. This is a slide from the gastric malignancy video where you can see the gastric mucosa has been just absolutely infiltrated and spread apart by these very uniform lymphocytes that we can see here on this CD20 stain are all B cells, confirming that we have this B-cell lymphoma. And then the final point I'd like to make is that when we're talking about our lymphomas, we need to keep in mind that they may transform to a more aggressive malignancy, frequently one that appears like a diffuse large B-cell lymphoma. So we can see this in our chronic lymphocytic leukemia, small lymphocytic lymphoma, as well as in follicular lymphomas. So this gives me the opportunity to talk about SLL, CLL. So SLL, CLL are essentially the same entity. We refer to them arbitrarily based on peripheral blood lymphocyte count as CLL when it's greater than 5,000 cells per microliter and SLL when it's less than 5,000 cells per microliter. This is an indolent or slow-growing tumor, and it's thought this is due not so much to increased tumor cell proliferation, but to increased cell survival. And this is due to increased amounts of the BCL2 protein, again inhibiting apoptosis. Now, part of the pathogenesis involves signaling through the B-cell receptor, which is, as you recall, surface immunoglobulin, which is going to activate the Bruton tyrosine kinase, or BTK. BTK is important because it's going to increase activation of genes that are important for growth and survival, and because we can use BTK inhibitors for sustained therapeutic response in a high fraction of our CLL patients. I've already alluded to immune dysregulation in CLL/SLL. We can see here these autoantibodies to red cells in about 15% of patients, but we can also get a hypogammaglobulinemia, which can result in an increased risk of bacterial infection. Now, what we'll see histologically will be effacement of our lymph node by sheets of small lymphocytes as well as larger actively dividing cells. And it's going to be this diffuse effacement, not that nodular effacement. So I've already shown you an image of this earlier. Now, again, you can appreciate why we used immunohistochemical stains. This is an SLL-CLL composed of a very uniform population of small lymphocytes. We can stain this with CD20 and CD5. And if you look back to that flow chart I had earlier in this talk, you can see how this will take us to our diagnosis. But I'm using this as a springboard to talk about how this can progress to a more aggressive neoplasm. So here you can see the small regular cells, but with the accumulation of additional mutations, we can get this very aggressive, very polymorphic large cell B-cell neoplasm. And this is going to have a worse prognosis than what you would see if you had a typical diffuse large B-cell lymphoma because it has additional mutations. So just finishing up, this can be very useful for you as a study guide, and I want to finish by looking again at these hallmarks of cancer because I think they're useful as a framework. So let's look here at another figure from Robinson Kumar Basic Pathology, and you can see here the different types of hematopoietic neoplasm and how they embrace the hallmarks of cancer. As usual, here are some questions. Feel free to pause this and see what you've learned in the last, 35 minutes or so. Thank you very much for your time and attention. Please do subscribe. I really would appreciate it. Thank you so much.